Okay, welcome to the first real full-length lecture. And this lecture we're going to use to expand upon the previous short lecture on the algorithm. So the algorithm here is going to provide the basis for us to really dig in deep to what I believe is a nice, efficient framework for examination and assessment that'll stand you in good stead throughout the NIOMT system. We're going to focus on clinical reasoning and thinking through each problem, and then we'll get into some examples at the end which will show you exactly how to apply this. So as we move into the examples here, we'll continually be able to reflect back on this algorithm which will take us through the entire NIOMT system. You'll recognize this algorithm from the last short lecture, and we're going to use it now as the basis to expand upon each of the principles individually. We'll start by focusing on the age, the gender, and the pain map, but most particularly the pain map, which there'll be a short lecture on following this. Before we go too further, it's definitely worth mentioning the role of the pathoanatomical diagnosis. NIOMT is a system that still believes that an accurate pathoanatomical diagnosis is both necessary and essential to the solid care of the patient. NIOMT also believes that there's adequate, if not pretty overwhelming evidence in the literature to support the idea that pain can be generated by musculoskeletal structures, but also identified by a careful tissue selective tension testing scheme. By utilizing appropriate subjective questioning and appropriate targeted specific objective testing that carefully identifies and localizes specific tissues that generate pain, we believe that we can put together an accurate, individualized prognosis and care plan which takes into account the specifics of tissue healing over time and the different functions that each tissue takes care of in the body. This makes us much more accurate as people. There's also the fact of probability. And if we look at the physical therapy examination, everything's about probability. Every time we make a decision or ask a question or perform an objective test, it is always aimed at either increasing or decreasing the probability that the hypothesis we're thinking of at that moment in time is either more or less correct. So probability plays an extremely large role in every single decision we make and should be reflected in the questions we ask and the tests that we perform. Occam's razor is a principle worth mentioning here. Occam's razor is the law of parsimony, economy, or succinctness. It's a principle that urges us to select from among competing hypotheses that makes the fewest assumptions. So that is, anything that seems logically right usually is and should be excluded before we go searching for much more complicated and complex answers, which in most cases are much less likely to be the correct ones. We're going to start with an example here, and this is a new patient that may walk into your clinic. We're going to call this girl Sally, for instance. We're going to say that she's a 16-year-old female who's injured her knee playing basketball the night before. She landed from a rebound, awkwardly on her knee, twisted, heard a pop, and then saw the knee swell, become painful, and become associated with much more difficult weight bearing as she presents to you in the clinic the next day. So the steps we'd go for, obviously we're going to begin with an assessment, initial assessment. You're going to view her, you'll see her immediately, you'll see her come in on crutches, you'll see her age. Your mind's immediately going to generate a hypothesis, and it's going to tend to be a pathoanatomical diagnosis. And in this case, because of the age, the gender, and the basic history that you know about this patient, it makes sense that we're going to go straight towards the knee, and one of the things that might come up as being obvious is an anterior cruciate ligament injury. This information is minimal, but it's also the most available, and using the principle of Occam's razor, it points us toward the most likely probability being first. And certainly, if we look at the literature that talks about young females and basketball injuries and knees, we would all have to believe that the anterior cruciate ligament rupture is the absolute most likely possibility first. So everything we're going to do in this examination now points directly towards that. This is our hypothesis, an anterior cruciate ligament rupture. It's our best guess about what's wrong with the patient. In this case, we know it from the literature, we have an intuitive sense, and we've probably seen this many times anyway. We're going to focus on one hypothesis at a time, and every question we ask or test we perform should now push us towards, looking at that bottom diagram there, should push us towards either referring out or treating based on the certain probabilities that were correct. An illness script, if we frame it in terms of the anterior cruciate ligament, an illness script is simply a set of characteristics that we ascribe to a certain condition that we've seen. It's a way that our brain uses to develop patterns in things that we've previously seen, so that when they repeat in patients, we have a set of conditions that we can identify. For instance, the pattern that we've talked about with the anterior cruciate ligament injury. We know the swelling, the pain, the mechanism of injury, and the presentation one day after the injury. Now that we've got this hypothesis, and we've developed a fairly good diagnostic possibility, and we've developed the probability scale about it, we can start to test it. We can use subjective and objective questions and tests that will help us to either confirm, deny, or completely eliminate the hypothesis as a relatively plausible explanation for the patient's symptoms. What we're trying to do is reach a diagnostic threshold beyond which any further information is extremely unlikely to change what we already believe to be true about the patient. And this is an important point to reach in any assessment. You've probably all seen this. This is the nomogram, and this is related to evidence-based practice, which allows us then to take a pre-testing probability and apply a test, and then use a combination of statistics with the likelihood ratio in the middle to either increase or decrease our original probability. In this case, you can see something's gone from 50 to 80%, which would obviously mean that a test is a fairly certain indicator of an increasing likelihood of the diagnosis being correct. At this point the diagnosis is made. We have a pathoanatomical diagnosis. We can now refer out if a diagnosis is something of a serious nature, or if there are any findings that confounded us or didn't make sense, or the patient then didn't fit within our scope of practice, because that really is the first decision we've got to make. Does the patient belong here? In this case, with an anterior cruciate ligament rupture, we do believe that the patient belongs here, at least for now. And we can move on, safe in the knowledge that we've got a diagnosis, to check to see if there are any dangerous signs, screen for evidence of serious pathology, and also look for involvement of other joints either above or below. Once we've done this, we have a much better etiological aspect to the examination, and we can understand some of the things that we need to do to begin helping the patient, as well as making that initial decision to refer out for imaging. What we're looking at now is post-diagnostic context. We're looking for the reasons that the exam problems exist, and for problems that we can begin to treat as physical therapy. Now that we're done with all the examination at the next step, the diagnosis is made, there's no safety issues, and the etiology is acquired, we can then at this point go in and review the medical history and the imaging. It's important not to do that beforehand so that we don't pre-bias our conclusions. We can also then move on to developing a specific prognosis and a treatment plan, which will include the most important concepts of activity, modification, hands-on treatment, and our physical and manual modalities that we like to use. The intervention, obviously we're going to be looking at intervention which is evidence-based as much as possible, and we'll see one of three results: success, failure, or no change. It's important that we continually reassess and continually become refining our hypotheses and going back and forth as we organize our information, being efficient and succinct. And at any time we fail, we go back to the drawing board to revise our hypothesis. This is one of the more important features of the examination. We can always go back to one of Einstein's, this is back to Occam's razor again, is everything should be as simple as possible but no simpler. Means we don't take shortcuts. We're still going to screen, we're still going to ask the serious pathology questions, but the bottom line is that we're actually going to get to the guts of the problem immediately and quickly and succinctly, and not waste time or energy with extra questions or examination features that really don't do anything to help us change our examination. I fully expect that this is going to generate some questions because it is different than the approach we've previously used. The keys here are to focus in on a hypothesis early as you can in the examination, and then focus only on those things that help you to refine that hypothesis. Once you're sure about the diagnosis, make it and move on to the etiology part of the examination. Don't ask questions or perform tests that don't help to get you where you want to go. We're going to talk a lot about this in class and use a lot of course examples.